Welcome to this program titled New Guidelines on Biologic for Systemic Lupus Erythematosus Management. I'm Marta Mosca, Professor of Rheumatology at the University of Pisa, and I'm joined today by Dr. Eric Morand, founder of the Monash Lupus Clinic and chair of the Asia-Pacific Lupus Collaboration, and who also participated in the development of the most recent updates of the EULAR guidelines for systemic lupus erythematosus. So welcome, Eric.
Thank you, Marta. Happy to be here with you.
So in this program, we will be discussing the recent updates to the EULAR guidelines for systemic lupus erythematosus and lupus nephritis. Today, our discussion will focus on the recommendations for biologic therapy to treat lupus and lupus nephritis. Many of the resources we discussed during this program can be found on the SLE Clinical Resource Centers on exchangecme.com. So Eric, let's jump right in. So based on the new EULAR recommendations, where do biologics now fit into the treatment algorithm for lupus?
Yeah, thanks, Marta. So I think it's important to review the changes between 2019 and 2023 guidelines that have been driven chiefly by the development of new evidence, especially arising from clinical trials. So in the 2019 guidelines, patients with lupus were divided into three categories: mild, moderate, and severe. We could have a whole debate about how to divide patients into those categories, but SLE and bile-ag domains are one way, and just involvement of important organs would disqualify from a patient being considered as mild. And in those 2019 guidelines, it was recommended that patients with so-called mild disease be treated in the first line with antimalarials and glucocorticoids, and if they were refractory to the addition of methotrexate or azathioprine. And then for moderate disease, first-line therapy was regarded as antimalarials and glucocorticoids, plus immunosuppressants such as mycophenolate, azathioprine, and also CNIs. And then refractory patients with moderate disease could have the addition of belimumab. And then in patients with severe disease, again, antimalarials and glucocorticoids, plus immunosuppression with mycophenolate or cyclophosphamide as first line, and then rituximab potentially added to that for refractory patients. So a big change, I think, is firstly the trials and approval of anifrolumab, bringing a new medicine to the table to be considered in these guidelines. And secondly, the movement of all of these therapies earlier in the treatment paradigm. So in the new guidelines, we still have first-line treatment of mild disease as antimalarials and low-dose glucocorticoids. However, second-line therapy for mild disease now includes the use of mycophenolate or belimumab or anifrolumab as equivalent to be considered equally in the treatment of mild disease not responding to first-line therapy. Then in the moderate disease, we also have a change wherein, again, the use of belimumab or anifrolumab is considered as part of first-line therapy alongside mycophenolate, methotrexate, azathioprine, and CNIs, in addition to baseline therapy with hydroxychloroquine and glucocorticoids. So there's a change that biologics now are not considered only for a refractory patient, but considered as part of the first-line options for moderate disease. Because the clinical trials of belimumab and anifrolumab included patients with moderate to severe disease, they're also included as part of first-line therapy for patients with severe disease. Importantly, anifrolumab is not approved for the treatment of lupus nephritis, but belimumab is approved now for the treatment of lupus nephritis. So for those severe patients, there's another first line there. So that leaves us in a place where for consideration of biologic, we don't need to have the mindset that the patient has to fail conventional treatment in order to be considered for a biologic. High-quality clinical trials included patients already on triple therapy with immunosuppression, glucocorticoid, and antimalarial, but also included patients in whom immunosuppression was unsuccessful or contraindicated and were taking only glucocorticoids or antimalarials. And so the evidence is there that biologics are effective in those patients, and that is where we should consider them. These recommendations, of course, subject to availability in your region, in your healthcare system, subject to reimbursement, etc. But here we're talking chiefly about what's the medical evidence, and that's the medical evidence, is that that's where those medicines should be considered. As we talked about in one of our previous get-togethers, Marta, the reason for driving this is to have more patients achieving treatment goals of low disease activity or remission. And the evidence from these trials is that rates of achieving low disease activity and remission are increased in patients who are taking biologicals in addition to standard of care compared to patients taking standard of care only. There's not much change for the second line and beyond therapy. Patients with life-threatening disease, IV cyclophosphamide should be considered, and rituximab may also be considered in refractory cases. Rituximab is off-label. It's never been formally approved by regulators, although in many jurisdictions it is allowed to be used under various conditions, and certainly most centres do use it in varying degrees, especially for refractory patients. So, Marta, what do you think about these updates? Do you think that this is going to change your practice in terms of considering biologics earlier?
I think that this is a very important point. Again, bringing what you were discussing, so the fact that we need to think about remission and low disease activity as early as possible with our patients, and we shouldn't wait of introducing an immune suppressive drug if this is not achieved with glucocorticoid low doses and hydroxychloroquine. We need to focus very clearly on the type of disease, on the flaring of the disease when we start our therapeutic approach, because we need to understand very rapidly which patients will benefit of an early introduction of immune suppressive drugs. I think this is a very important message for all the clinicians caring for patients with lupus, that after the failure of one treatment, you shouldn't wait more, because otherwise patients will accrue damage and will use too many glucocorticoids. So that's why I like this update very, very much, because the anticipation of the immune suppressive therapy is very important. And this, in a way, as you were saying, is not related strictly with the type of treatment, but with the concept of using the immune suppressive therapy. Obviously, if you have a biological therapy, then you will have more data. So the advantage of what you were saying, having clinical trials and lots of data on biological therapy, is very clear. So where there is an availability, you would love to use them as early as possible, because now we know a lot about the achievement of targets while using these drugs, and also sometimes about the time needed for response, which, is not so clear for the old immune suppressive drugs. And it is also an important point. When is the moment to decide whether a treatment is not working for our patients is the next step. But with the new drugs, we have more information. So obviously, the idea of using biological drugs earlier is there, obviously related with the need to sustain costs, because as doctors, we also have this responsibility with our healthcare systems and our patients, so that care should be affordable and should be maintained. And this is different in different countries. The other very important point is that now we do have data on also the long-term safety and efficacy and tolerability of many of these drugs, because one could say, oh, we've been using all drugs for a long time, so we know them better. But we know a lot also from biologicals. So I think that the long-term data should also tell us that there is a lot of information. So what comes with new trials is that we know a lot, a little bit faster from new drugs. So we do have data on the long-term efficacy and tolerability of belimumab as an example over time. Belimumab has been used now for up to 13 years, even more. And we know that patients presenting side effects are few. Over time, there is a good retention on this drug, and particularly patients continue to improve while they are treated with belimumab, and they are able to achieve the target of low doses of glucocorticoids. So this is very important. As well as the long-term extension data of the anifrolumab trial, the TULIP long-term extension data. Now there are data of a 3-year long-term extension on the use of anifrolumab. And again, obviously, there are data supporting the fact that the data on tolerability are very good. and there are no safety findings or new safety findings over the long-term use of these drugs. So a favorable benefit-risk profile for anifrolumab in patients with moderate to severe lupus. So this is obviously a very important point. Another very important aspect, and here we, put other information on the use of these drugs, are the post-hoc analysis, and after the TULIP program, an analysis was done in patients treated with anifrolumab, and we can see that patients who were included in the study were in remission for a long-term time, and this as well is what we want to obtain for our patients. Here you can also see how the use of anifrolumab supported reaching the targets that we were discussing. So the fact that what we want for our patients is to put them in remission, but not only to maintain them. That is the other very important point, because we touched on the targeting and reaching the targets, but it's not just reaching the targets that we want while we treat our patients, but it's preventing flare. And so is the time the patients spend in remission. And for example, patients treated with anifrolumab spent a greater percentage of time in remission and are likely to be in remission for more time than patients treated with standard treatment. So as we can see, what happens is that with the use of biologic, indeed, we have lots of data telling us the achievement of targets, but as well as the maintenance of targets over time. And this is really meaningful in the long term for our patients. So, Eric, it has been a pleasure to be with you today and to discuss with you about these important points. And thank you all for joining us for this discussion on the recent updates of the EULAR guidelines for the treatment of systemic lupus and lupus nephritis. Please review the other videos in this educational series focused on improving care of patients with lupus and lupus nephritis. Please subscribe to Exchange CME's YouTube channel and check back regularly for updates and new videos.